Good afternoon. I would like to start by thanking the organizers, Dr. Dumra, for inviting me over to give this talk on COPD and the year in review as far as COPD is concerned. It's indeed an honor, and I shall try and give you an update on what I think was something that was important as far as COPD was concerned. So, one of the major things was that we saw in COPD was the GOLD 2023 guidelines. And the issue here is what is special about it and what is different from what we already know in terms of our management strategy as far as COPD is concerned. The definition, of course, of COPD was changed by the new guidelines in terms of that it is a heterogeneous disease characterized by chronic respiratory symptoms, dyspnea, cough, sputum production, exacerbation due to abnormalities of the airway. So accepting that there is bronchitis and bronchiolitis and the alveoli, that this can be emphysema also, that causes persistent, often progressive airflow obstruction. So that is an important thing to keep in mind. But I think the other important thing to keep in mind is the diagnosis. And it's important to remember that we rely a lot on spirometry, but a lot of data suggest that spirometry is not something which is the best way to diagnose COPD. If you look at this paper, and this looked at number of articles, one of spirometry was insufficient to rule in or rule out mild to moderate chronic obstructive pulmonary disease. And they really saw that a single post-dilator spirometry test is insufficient to confirm or exclude COPD when the FE1 by FVC ratio is close to the threshold. If it's close to 0.7 or 0.65 to 0.7, the diagnosis is difficult, and sometimes it may not be definite. And certainty in diagnosis becomes possible only when the obstruction becomes more severe. And that's what this showed, that if you have a ratio between 0.65 to 0.7, if a person quits the exposure, for example, quits smoking, you may repeat this spirometry after 5 years and you may find that there's a reversibility as far as the disease is concerned. Similarly, if you have a person who continues the exposure, it may be borderline, but it may progress to less than 0.65 or to less than the fifth percentile of the lower limit of normal. A lot of data suggests that there is what we call instability rate, which can vary from 6.4 to 20%. It means that if you were to look at one spirometry, in almost 20% of the patients, if it was borderline, you may actually misdiagnose or not be able to diagnose COPD properly. Also, something that we've been talking of in this paper in the European Journal looked at symptomatic smokers without COPD having physiological changes and looked at the development of COPD. The reason why this paper is good, because this followed up these patients for a very long period, almost 10 years. And what they found was, and then they looked at those patients who were symptomatic smokers but did not have COPD as per the definition, 65% of these non-COPD patients had a mid-expiratory flow rate of less than 80%, and 38% had abnormal DLCO. And those with no COPD, but with a low mid-expiratory flow rate, they performed worse as far as 6-minute walk tests were concerned. They were more dyspneic, and they had a higher prevalence of chronic bronchitis as compared to those who had a high mid-expiratory flow rate. But what was interesting is when they followed up these patients, they found that by the 10th year, V3 was the 10th year of their follow-up, 21% of non-COPD patients with a mid-expiratory flow rate of less than 80%, as compared to 2.7% of those with a mid-expiratory flow rate of more than 80%, went on to develop COPD. And therefore, the argument that they put forward is that this is a test which may be useful in symptomatic chronic smokers who don't fit the criteria as far as COPD is concerned. And if you look at the numbers here, subjects who develop COPD after 10 years, it was 21% in those who had no COPD and had a low mid-expiratory flow rate. So it's worthwhile to look at this value. And if you remember, almost 20-30 years ago, one would talk of FEF 25 to 75 as a diagnosis of small airway disease in smokers, and you could say that this was one marker which would tell you which group of patients would go on to developing small airway disease, and later on which was that group of smokers which had a higher chance of developing COPD as compared to those smokers who had a lesser chance. Remember, all smokers don't go on to develop COPD. All of this led to the gold criteria of looking at what was known as pre-COPD and PRISM. The concept of pre-COPD came up because of a lot of such papers which showed that your FE1 by FVC ratio is not that robust, and then there are other symptoms which may be present or other findings on spirometry which may be present, which may actually give you a clue that this person may go on to develop COPD. So pre-COPD is respiratory symptoms and structure and function abnormalities without airflow obstruction on PFT. So if your X-ray or CT scan shows features of emphysema, but lung function is normal, you could, and the patient has respiratory symptoms, it could be pre-COPD. And PRISM is when you have preserved ratio of FEV1 by FVC ratio, which is greater than 0.7, but spirometry is still impaired. Your FEV1 or FVC is less than 80% of predicted after bronchodilation. So you have a low FVC, there is some air trapping happening, but the ratio is preserved. So by your definition, this is not obstructive airway disease, this doesn't fit into the criteria of COPD, but you have other abnormalities. All of these are factors which tell you that this is a group of subjects who later on can develop COPD, and there is a need to try and intervene early. So what can we do? One can look at smoking cessation, decrease environmental exposure. We still don't have enough data as to whether early initiation of any pharmacotherapy will help this group, but this is something that is a point for ongoing research. Then we have the chronic bronchitis, new terminology which was first not there in the GOLD guidelines, defined as the presence of expectoration cough, expectorant cough with sputum on regular basis. We had the old definition which said cough with expectoration for at least 3 months in a year for 2 consecutive years. It's, the definition has probably come back, and I personally feel that we have sort of come back to what we as students learned of different phenotypes of COPD. The chronic bronchitis phenotype, which was the cough with expectoration, where we said there was mucous gland hyperplasia, Reed's index was abnormal. We had the what was known as the asthmatic bronchitis phenotype, which is the asthma COPD overlap, the pink puffers, which was the emphysema type of phenotype, and the frequent exacerbators, or what was also at that time known as chronic mucopurulent bronchitis, where there was a large number of mucus production because of underlying associated bronchiectasis. So I think we have started looking at the same thing, but from a different view as far as the recent guidelines are concerned. The recent guidelines also have now looked at what is known as etiotypes of COPD. And this again becomes important because we're now understanding that, like we talked of asthma, that asthma has different phenotypes. TH high, TH2, eosinophilic, non-eosinophilic. Probably there is also different etiologies as far as COPD is concerned. So it could be genetically determined, which depends on genetic variations, why some smokers develop COPD, others don't. Then it could be due to abnormal lung development. Early life, premature birth, low birth weight could all be related to that. Environmental factors, cigarette smoking, COPD-C, but biomass and pollution exposure, which could be COPD-P. And I've always wondered, should we add another criteria here which may be different, that is COPD occurring because of BD smoking. So it could be COPD-B for that matter, because that is something we see very often in our country. Then COPD due to infections. Childhood infection, tuberculosis, we see a lot of what we used to call TOPD, tuberculosis obstructive pulmonary disease. And TOPD is basically some patients of tuberculosis continue to have airway obstruction and show features of obstruction. And there is now a large body of data from South Africa, from Korea, which suggests that a subgroup of patients with tuberculosis do behave as COPD as the disease progresses. And then of course asthma and COPD of unknown cause. What this has led to is a different flow chart where one has again started looking at, rather than the A, B, C, D criteria, and A, B, and E criteria, where E is now looking at either LABA-LAMA or a LABA-LAMA inhaled corticosteroids. So have we come back to the use of inhaled corticosteroids as we were long time back? So I think the question that has been going around for the last few years is, in COPD, do we give or do we not give inhaled corticosteroids? And I think we are moving around in circles because this is something that we discussed almost 15, 20 years ago, and the guidelines have again brought it up. But if you remember, long time back, we had this classical chart where we said that you had people who had breathlessness, who benefited both from bronchodilators, and those who had risk for exacerbation who benefited more from inhaled corticosteroids. And this was based on studies which were done almost 20 years ago. I'll just run through those studies. The first study was done way back in 2020, published in the BMJ, which was the ISOLITE study, a randomized double-blind placebo-controlled study of fluticasone in patients with moderate to severe chronic obstructive pulmonary disease. And what this study clearly showed was that fluticasone propionate reduced exacerbation and health status decline, providing a rationale for use of inhaled corticosteroids in COPD patients. Subsequently, we had the COPE study, which again looked at that if you discontinued inhaled corticosteroid in patients with COPD, it was associated with more rapid onset and higher recurrence rate of exacerbation. Again, this study was done way back in 2002. And then there was analysis done of inhaled steroid effect evaluation in COPD, a meta-analysis of 7 large RCTs, and this also clearly showed that there was benefit of giving inhaled corticosteroid. And what they really showed in this was that treatment with inhaled corticosteroid was associated with a 27% reduction in all-cause mortality in individuals with stable COPD. Remember, these are studies which were done long time back. So all of these studies, trials which were done, showed significant role of inhaled corticosteroids as far as COPD is concerned. What turned things was the TORCH trial. The TORCH trial, which was actually looking at salmeterol, fluticasone and survival in COPD, did not find a survival benefit. But it's interesting that to look at the p-value, it just missed being statistically significant. The p-value was 0.052. So if they had just a few more subjects, it would have reached statistical significance. But it did not reach statistical significance, and the authors concluded that probably steroids have not any role. But what was more important was that they also said that there is a high probability of having pneumonia when you're giving steroids. And this really changed the whole picture that are we causing more pneumonia in our patients. So they said reduction in death did not reach statistical significance. However, improvement in FEV1, exacerbation, health status supported the use of ICS LABA in COPD patients. And this was the first study which detected pneumonia. And this led to the huge change that we saw after 2010 or 11, that we should decrease the use of corticosteroids in our patients with COPD. And then we had the ultra-long-acting LABAs and LAMAs coming into place, where they were being more aggressively promoted, and steroids found a lesser place as far as treatment was concerned. And based on that, the GOLD guidelines focused a lot on either a LABA, a LAMA, or a combination, until we had this whole issue of trying to give inhaled corticosteroids. So if you look at the current guidelines, it says LABA, LAMA, but also says consider inhaled corticosteroids if blood eosinophil count is more than 300. But we have a large number of now recent trials which have tried to really address this issue. And triple therapy in COPD, these are these landmark trials, the IMPACT trial, the TRibute trial, and the ETHOS trial. All of them showed that triple therapy is associated with significant reduction. IMPACT showed a 25% lower rate of moderate to severe exacerbation, a 42% all-cause mortality decrease as compared to LABA-LAMA combination. TRibute trial also showed a lower rate of moderate to severe exacerbation, and the ETHOS trial also showed a lower risk of severe exacerbation. So we have come back to what we sort of evaluated more than 15 years ago. They were then given separately. You had LABA, LAMA and ICS being given separately. Now you have a combination, and more recently trials have started to look at the cost effectiveness. So this is a paper which was published last year which looked at cost effectiveness of once daily inhaler in COPD triple therapy in Spain, and this was again a part of the IMPACT trial. And this again showed that by giving triple therapy, it was cost effective as compared to when you were giving just a LABA-LAMA combination in these patients, because it decreased the risk of exacerbation across all scenarios and sensitivity analysis. So this was across the board. It was irrespective of the eosinophil count. This is another paper published last year which looked at the benefits of giving budesonide, glycopyrandium, formoterol fumarate, dihydrate on COPD exacerbation, lung function, symptoms, and quality of life across blood eosinophil range. Here again, although the benefits was more in those who had a high eosinophil count, even if your eosinophil count was more than 100, there was a benefit, and they found this was independent of the eosinophil count. So again, eosinophil count is useful, but there are other factors which one must consider when one is thinking of giving inhaled corticosteroids in patients as far as this is concerned. So what does the GOLD now say? The GOLD guidelines say that ICS LABA are more effective in reducing exacerbation in moderate to severe COPD, but regular ICS increases the pneumonia risk, especially in severe disease, and eosinophil count less than 2%. Triple therapy improves symptoms, lung function, health status, reduces exacerbation with possibly mortality benefit in frequent and severe exacerbators. I think we've come a full circle, and in my mind, if you're looking at giving triple therapy, if you have a person who has history of hospitalization for exacerbations, more than 2 moderate exacerbations per year, has history of concomitant asthma, possibly has eosinophil more than 300, you should definitely consider giving inhaled corticosteroids to these patients. One other rider which was there in the previous guidelines was if you had your FEV1 less than 50% post-bronchodilators. That meant you had more severe disease and therefore had a higher chance of having exacerbation. If you have more than 1 moderate exacerbation per year or your eosinophil count is between 100 to 300, again one should consider giving steroids. When do you not consider giving steroids? Repeated pneumonia events, very low blood eosinophil counts, or when you are worried about tubercular infections or mycobacterial tubercular infections. So I think it's important to keep this in mind. And what we were discussing almost 15, 20 years ago, I think we were just re-emphasizing that in a subset of patients who have recurrent exacerbations, who have more severe COPD, even if the eosinophil count is high or not, you should consider ICS along with the LABA-LAMA combination. The guidelines also look at exacerbation, and the guidelines have changed the definition that COPD is defined, exacerbation is defined increase in dyspnea and or cough and sputum that worsens in a period of less than 14 days and may be accompanied with tachypnea and tachycardia and is often associated with increased local and systemic inflammation caused by infection, pollution and other insults to the airways. Now, is there anything new that we can look at? And very often you have patients whom you're wondering that, you have a patient of COPD with acute exacerbation on NIV, you're worried that this patient is now not improving. Will you land up to have to intubate this patient and then put him on a ventilator, which you would like to avoid? So there's one Cochrane review which looked at the use of magnesium sulfate. Now remember, Max-Sulf is something that one uses in severe asthma when you have an acute exacerbation. This paper looked at magnesium sulfate in COPD. And they looked at around 11 trials. 7 were looking at magnesium sulfate IV versus placebo. 1 looked at nebulized, 3 looked at nebulized magnesium sulfate, and 1 looked at magnesium sulfate versus ipratropium bromide. So they found that IV magnesium sulfate may be associated with fewer hospitalization and improved dyspnea compared to placebo. There was no difference between magnesium sulfate and infusion and placebo for NIV, lung function, SpO2 and adverse effect, and for nebulized magnesium sulfate it was unclear about its effect on exacerbation for most outcomes. But what it really showed was that if you looked at hospital admissions, there was a tendency to favor giving magnesium sulfate, although the number of participants was low, therefore the great quality of evidence was low. The need for NIV, there was really no difference as far as magnesium sulfate was concerned. But length of hospital stay was also much less as far as magnesium sulfate was concerned when we looked at placebo. And adverse effects was not very different. There was no reported serious adverse effect. So what does this mean? It means that IV magnesium sulfate as an adjunct to standard care showed lesser hospital admission, lesser length of hospital stay, reduced dyspnea scores and improvement in PFR. Nebulized magnesium sulfate versus placebo reduced ICU admissions, improved PFR and dyspnea scores. However, the number of studies are small and we need more data, but something to keep in mind when we're dealing with a patient with acute exacerbation of COPD who's not responding and you're really wondering, do I need to intubate this patient because he is not responding to the bronchodilators I'm giving him, the steroids I'm giving him, and the patient is already on NIV. There's also the management of stable COPD during COVID pandemic, but I think what COVID pandemic taught us was not this, it taught us something else. And that was that the use of home-based pulmonary rehabilitation, and that this is something that can also be done. We talk a lot of pulmonary rehab, and since I've been involved in this for many, many years, I know that it's very difficult to do a hospital-based pulmonary rehab. Your dropout rate is very high. The patients will come to you for the first few weeks, but then compliance becomes much less and less because they're not willing to come regularly to the hospital to do a rehab. And therefore, there are various trials which have looked at how can we look at now a telehealth or pulmonary rehab based treatment. So this is one paper published last year which looked at the effectiveness of home-based pulmonary rehabilitation, a systemic review and meta-analysis, looked at 16 studies, 1800 COPD patients from 11 countries, and they looked at the effect of home pulmonary rehabilitation on exercise capacity and quality of life compared with either center pulmonary rehab or usual care or both. And compared to usual care, home pulmonary rehabilitation significantly improved exercise capacity and health-related quality of life. And when they compared the center pulmonary rehab versus home PR, there was no difference in exercise capacity and health-related quality of life. What it basically means is that pulmonary rehab done on a home basis is as effective or equally effective as a center-based rehab if it is properly structured and done in a good manner. And what this showed was that if you looked at comparison between home PR versus usual care, it did favor home PR in most of the studies where it looked at health-related quality of life or the 6-minute walk test. Even if you looked at home PR versus center PR, there was really no difference as far as health-related quality of life or the subgroup analysis was concerned. And this has been there in a large number of papers over the last 1 year. I think some of the fallout of COVID, because this is something people started doing because of COVID-19. This from the from American Thoracic Society, the ATS journal, long-term rehabilitation or unsupervised training at home for patients with COPD. This was a randomized controlled trial, and again they found that long-term tele-rehabilitation and unsupervised exercise training at home were both successful in reducing the number of hospitalization and ED presentation of patients with COPD. Tele-rehabilitation and unsupervised training group experienced better health status for 1 year, and intervention participants reached and maintained clinical significant improvement in exercise capacity. And because of this now, tele-rehabilitation, a term that we were not using that frequently a few years ago, has become something which is really more and more prominent. And there is a Cochrane review, there are a large number of papers which have come in last year focusing a lot on pulmonary tele-rehabilitation. And in a country like ours, where sometimes it's difficult for patients to come from a remote area to a main center, it's something that we should focus on and try and push to really provide good quality care. We did a study many years ago where we looked at rehab versus yoga and found that yoga, if done properly in a structured manner, is also equally effective. And I feel that we can take that forward in terms of trying to develop a rehab program using yoga and yoga-based exercises. Moving on, this is something that Dr. Vishweshwaran discussed in the morning, home oxygen for moderate hypoxemia in chronic obstructive pulmonary disease. And this paper came in last year as systemic review and meta-analysis. And the research question was, does home oxygen therapy improve survival in patients with COPD and moderate hypoxemia? We have definite indication for long-term oxygen therapy, a PaO2 of less than 55 or 55 to 59. If you have other features which suggest pulmonary arterial hypertension, polycythemia, but in a patient who has some degree of nocturnal dip or fall in saturation during exercise, is there a role for giving long-term oxygen therapy? So they looked at 6 trials, 2 at long-term oxygen therapy and 2 looked at nocturnal oxygen alone. All studies were negative for outcomes of mortality. And they concluded that home oxygen makes little or no difference in 3-year mortality in patients with COPD with moderate hypoxemia. It's now that people have become more conscious of oxygen therapy post-COVID, a lot of people have started using oxygen even if they don't have significant degree of hypoxemia. And this really was a negative study which showed that there was no role as far as giving oxygen to these patients were concerned in terms of mortality benefit. Quickly, there's this other study which again there's a lot of issue of do air purifiers help or not? So this was a randomized clinical trial of air cleaners to improve indoor air quality in patients with COPD, the Clean Air study. And this was a sham-based study. So they looked at COPD patients who received active or sham portable high efficiency air cleaners, and they followed up the patients for 6 months. They had 116 participants. And although there was no statistical difference in total SGR, St. George related respiratory questionnaire, but there was a reduction in symptom subscale, respiratory symptoms, and lower rate of exacerbation and rescue medicine as compared to the sham group. So there was some data to suggest that this group is air purifiers do help. The rescue medication came down significantly in the active group. Moderate exacerbations came down. There was no difference as far as severe exacerbation was concerned. So again, another question which a lot of pulmonologists are asked, is there a role of using air purifiers as far as COPD patients are concerned? This study also showed that those who stayed indoor more benefited much more than those who spent less time in the room where the air purifier was being used. There have been a lot of focus on interventions and in terms of patients with COPD, from chronic mucus production to exacerbations to various interventions up to lung transplant. And there has been a paper which tried to look at survival in COPD patients with bronchoscopic lung volume reduction. I'll just finish in another 30 seconds, which basically again showed that there was a definite improvement when they followed up these patients. These patients were followed up for almost 7 years and 7.4 years, and the median survival in the patients who had bronchial lung volume valve replacement was almost more than was greater by 630 days as compared to those who did not. So there is definitely a role of looking at bronchoscopic lung volume reduction surgery, and this actually tends to show a survival benefit in these patients, that there was a survival benefit in those patients who went in for bronchial lung volume reduction surgery. There is now a lot of interest in biomarkers in COPD, and there's a lot of research being done basically to look at various biomarkers and looking at COPD from the environmental point of view, clinical point of view, biological point of view, and genetic level, and the fact that we can look at it from different points of view. Reduction in prevention and identifying persons at risk, the pre-COPD or the PRISM group, looking at air purifiers, reduction in prevention and identifying risk, looking at genetic factors, and of course then looking at clinical care, personalized medicine, guideline network, identifying overlaps, and looking at markers which may help us as far as diagnosis is concerned, and looking at therapeutic targets. So I'll stop here. Thank you very much.